Three of our fabulous speakers who are going to kick us off. Mufalo Cheatham, Dr. Eric Steele, and Mohammed Khalif. I'll start with Mufalo. And there she is on the picture there. Mufalo Cheatham is the executive director of the Maine Immigrant Rights Coalition, which oversees 85 partner organizations across the state. The Maine Immigrants' Rights Coalition is the convener of a unique statewide network of 85 organizations, a majority of which are led by people of color, representing diverse ethnic communities across our state. All coalition member organizations are working to create and support programs and policies that promote immigrant inclusion and integration. MERC represents member organizations that include immigrant constituency groups, advocacy groups, direct service organizations, and grassroots community organizations. She was nominated by Adila Muhammad, executive director of the Third Place, as a strong statewide leader. Our next speaker is going to be Dr. Eric Steele. And there he is. Eric Steele is a board-certified family physician practicing family medicine primarily at the nonprofit primary care and insurance company, Martins Point Healthcare. He is also president of the Maine Medical Association. Eric has practiced primary care for more than 30 years and emergency medicine in rural Maine hospitals for more than 20 years. He has served in several leadership roles in healthcare, including as chief medical officer of two large integrated delivery systems, CEO of a rural Maine hospital, and ED administrator for a large tertiary hospital. He has led and participated in numerous collaboration projects between different specialty areas of the healthcare delivery system, including between emergency medicine and occupational medicine, emergency medicine, and primary care. Eric was also a medical columnist for the Bangor Daily News for 17 years and written and presented frequently on a broad range of healthcare topics. Dr. Steele is a graduate of Bowdoin College and the University of New England College of Osteopathic Medicine. He lives in Yarmouth with his family. My next speaker will be Mohammed Khalif. And there's a picture of Mohammed. In 2019, Governor Jay Inslee appointed Mohammed Khalif to serve on the State Medical Graduate Work Group. His organization successfully advocaate for licensing reform every year since 2019 and helped pass legislations during those times. The most recent legislation, HB 1129, established a license for unmatched doctors in Washington state. It was featured in several articles, including Federal Trade Commission Watch, Long Reads, and Times Magazine. Dr. Khalif also speaks at educational seminars and webinars related to brain waste and workforce integration. His most recent presentations were at the World Education Services and the Healthcare Leadership Table. On his free time, Mohammed loves playing basketball and is a diehard fan of the Phoenix Suns. That's awesome. Okay, so I am going to invite Mufalo to speak first, and we're going to highlight her so you'll be able to see her. And let's see, Mufalo, there you are. Great. This is your time. Thank you, Mufalo.
Good morning. Can you hear me?
Not very well.
Can you hear me?
You got to be a little louder.
Okay. Good morning. Good morning. Is that better?
It's getting better.
Okay, sorry. My signal in my house today is not good, so my sincere apologies. Thank you. I can take it away?
Yes, please.
All right, thank you. Well, what a great and unifying event this is, so thank you so much. On behalf of our immigrant communities in Maine and the Maine Immigrant Rights Coalition, I'd like to thank the New Mainers Resource Center for this invitation to share some opening remarks. Ability simply refers to the potential of a person to do something. On the other hand, skill is the potential possessed in an individual to do something exceptionally well. Immigrants come to Maine believing in themselves and their abilities and their skills. And they have a drive to achieve their dreams. But very, very quickly, that reality sets in and their dreams go off. And all the confidence that they came into the United States goes with them. As for me, it took me 18 years to get a professional position that matched my foreign Bachelor's of Art degree. I had to use my passion to bring to life my dad's degree by telling stories of trailblazer women who are defying odds and are now part of changing Maine. That platform I created called Empower the Immigrant Woman in March of 2016 not only gave me back my professional life, but it showed others that what was on my resume with a Zambian Bachelor's of Art degree said was more than what I was. I was qualified, I was experienced, and I was capable to lead and direct. It is so fulfilling to work for a cause so dear and near to my heart, advocating and advancing the rights of immigrants in Maine. At Merck, we now have a platform that is here to ensure that foreign-trained immigrants can be hired as physicians and can help diversify the medical profession in Maine. In this forum today, you will hear, or it will confirm what many of you already know. On the other hand, it will also simply exemplify what meaningful investment in foreign-trained immigrants looks like. In our state, and also national systems and institutions, they are currently reproducing patterns of hiring resistance. Therefore, let us work together from a place of professional respect and mutual appreciation of skills and abilities, regardless of which country one attained them from. I therefore urge you to look through the eyes of these immigrants and see, so that when you leave this space, you can ask different questions, but you can also we can also invite in this space something new. Thank you.
Thank you, Mufalo. Thank you very much. And next, our speaker will be Dr. Eric Steele. Eric, we're going to highlight you there. Hold on. There we go.
All set?
All set.
Thank you, Judy Ann. Good morning, everyone. It's a pleasure to be speaking with you today and to extend greetings to you from the Maine Medical Association and its 4,000 plus physician members. The Medical Association, the MMA, has as its mission to support Maine physicians, to advance the quality of medicine in Maine, and to promote the health of all Maine people. Consistent with that mission, the MMA has a long history of supporting foreign-born and foreign-trained physicians in the practice of medicine in Maine, and I believe there are now more than 600 such physicians currently licensed and living in Maine. The MMA board includes 2 such physicians, Krishna Bhatta, who was a colleague of mine at Northern Light, the physician who spent his career in urology, providing urology care in central and northern Maine, served as president of the Maine Medical Association from 2002 to 2003. I've worked with a number of those physicians in patient care all over the northern half of Maine. Foreign-born physicians hold a number of leadership positions in Maine hospitals. I've hired several of them myself in my leadership roles. A few have provided care for family members of mine, and I regard all of them as colleagues of mine in the care of the people of Maine. Success in bringing excellent foreign-born and trained physicians into Maine to practice is critical to the care of Maine's people. We simply would not have enough physicians in Maine without our colleagues from other countries. And those physicians often serve in rural Maine. And without their care, many rural Mainers would struggle to have access to primary and specialty care. So success in bringing excellent foreign-born and trained physicians to Maine is also important in the care of the growing number of foreign-born Mainers. These patients need physicians who understand them, relate to them, know their culture and values. but our white population also needs to experience diversity in its caregivers. And I think that to receive great care, for example, from a physician of color from someplace far away is a culturally important and eye-opening experience that many of us can benefit from in more than just a clinical way. For those and other reasons, diversity and equity in care are things that the MMA and its partners in the Daniel Hanley Center for Healthcare Leadership actively support. And in my role as the MMA president, it's my hope that 2025 will see a statewide conference on diversity and equity in healthcare in Maine, hosted by the MMA, Hanley, and other key stakeholders in that work. The MMA also has a long history of supporting a safe, reliable, careful, and transparent process for the licensing of physicians in Maine. Such support is also consistent with our mission. We support a process that is as efficient as it can be without compromising the safety and effectiveness of that process. And we support reviews of this process as to how it can be improved without compromising its effectiveness. The credibility of the licensing process is foundational to the credibility of all physicians in Maine, and failures in the licensing process or the credentialing process by healthcare organizations could result in diminished public confidence in all physicians. So a great deal is at stake whenever change is considered for the licensing process. But the MMA welcomes this discussion and the work of sustaining a diverse and well-trained physician workforce for all of Maine. And I thank you all for creating this forum to advance that discussion and for your time and attention today. Thank you.
Thank you, Eric. Now, Mohammed Khalif. We'll highlight Mohammed.
Hello, everyone. Thank you so much for having me. My name is Mohammed Khalif, Executive Director of the Washington Academy for International Medical Graduates. We're a nonprofit organization. And I don't know, Vanessa, if we wanted to share the slides right now or if it's going to be in another section. Yeah, but I have a short slide for everybody to consider. And so a little bit about my background. I'm an immigrant myself from Somalia, immigrated to the country when I was young. Eventually, my father found a job in export and import, bringing immigrant and refugee products here in the United States. So I had to live in 6 different countries. Ultimately did my high school and medical school in Asia, in China mainly, and graduated with a medical degree in China, and then came back here to the United States. And, you know, as an IMG, went through all the process, and it was very difficult. So I created, and with the help of my colleagues, this organization that helps international medical graduates in Washington, and also provides consulting to other physicians and stakeholders who want to continue this work in different states. So our organization was created in 2019 to address and break down barriers that prevent Washington international medical graduates from accomplishing their professional and medical career goals. Our organization supports immigrants and refugee physicians who have obtained their medical degree abroad. And we help with 3 main things, mainly career preparation, professional development, and licensing and credentialing guidance. Next slide. So in Washington, we help our members, around 500 IMGs, mainly immigrant and refugee physicians. They speak 20 different languages. 93% are underemployed, unfortunately. The most common employment is Uber. So this is a really good graph I made. It kind of like depicts, it tells a story of IMGs, international medical graduates, and some of the things that they need to go through when they come to the United States. So it's mainly 3 buckets. One is called the ECFMG certification. The second bucket is graduate medical education, which is 3 to 8 years of residency training. And the last one is the Washington license, or any state license that they qualify for. And I showed some of the barriers that people go throughout the way. So the first area, as you can see in the top, there's a lot of people who start off, and then the people shrink with the green arrows as they go throughout the process. And The reason is the ECFMG certification is, I would say it's not easy, but it's still easier compared to the graduate medical education. And once somebody gets into residency, they have a really good chance of getting licensed. So ultimately, you can see there's the same number of people from residency to licensing, even though some people fall off in residency, but it's not as vast as compared to the graduate medical education process. So when they arrive in the United States, they have to go through an organization called the Educational Commission for Foreign Medical Graduates. So this is a nonprofit that certifies them, they give their diploma to them, and then they check if their school is accredited internationally, they submit their transcripts, and then they sit for 3 exams, which is called the USMLE exams, which basically step 1 focuses on the basic sciences, step 2 focuses on the clinical skills. They don't have CS anymore, but usually focused on skills related to the patient's, the physician's office, and just interacting with patients, interpersonal and patient notes, etc. So there are 3 barriers when it comes to completing the test. One is employment itself, because a lot of people don't have jobs to pay for the test or pay for the process. So that is a huge barrier, especially somebody who just came to the country as an immigrant or refugee. And so exam cost might be a problem. The second barrier might be mentorship. Maybe they don't have anybody who's gone through the process and to talk to them about this issue. So that's another barrier as well. So we try to help them with some of these stuff so they could take their tests. And when they complete this portion, next they need, and they pass the test, they need to go through graduate medical education training. So this is residency training. This is an annual process where everybody applies to a application called ERAS application, and they have to submit their scores. They have to go on interviews across the country, and they have to be selected into one of those interviews with the residency program. So after they start, it might take 3 to 8 years to complete the residency and then get their license. So next slide. And it's really hard. And some of the, sorry, let's stay on this slide before one more minute. I want to talk about the barriers. So one is the barriers to getting into residency is clinical experience. So the issue with clinical experience is a lot of program directors or a lot of residency programs will tell you, hey, before we can admit you, you need to get some clinical experience in the United States because we don't know about your clinical experience abroad. So a lot of people, they try to get this clinical experience somewhere, but when they go to hospitals, they say, oh, we can't, have somebody doing clinical experience if they're not licensed. Sorry, we can't work with you, we can't help you. Then they have to stick with something called shadowing. And sometimes a lot of programs these days are not considering that as a clinical experience. So that's a barrier as well. One thing could be a graduation year. So even though if somebody was, let's say, practicing in Afghanistan or Ukraine for 5 years, and then they immigrate here, those 5 years or those 10 years that they've been practicing is not considered a clinical experience. So, and they're considered like they're old graduates. So they're considering the graduation date from medical school and not everything else after that. So that is a barrier as well. And a lot of people end up not getting interviewed or not being picked up by the system because of their old graduation year. And another thing might be geographical area, because some states have more traditionally selecting more IMGs than the other states. And the other thing is limited residency spots. And I want to talk about that in the next slide as well. So residency is funded by the federal government. And in 1997, there was a cap by a Balanced Budget Act that limited the number of positions. So you can see this graph, the green line is the total number of applicants. So, and this is going up every year. And the purple line is the total number of positions. So there's going to be more applicants than the number of positions. So, and ultimately it becomes a game of musical chairs. So even though people have good scores, they have good, credentials, eventually there's no place to sit because programs have a limited spots for much applicants. For example, my family medicine program here in the University of Washington, I think so, they told me they get 2,000 applicants for 10 spots. So it's very difficult to get the spot, especially if you're foreign trained and if you're competing for these positions. Next slide. So in Washington, we passed something called House Bill 1129. And what we said was the state would grant a limited license to IMGs who pass all their USMLE exams, and they could practice under the supervision of a physician who's board certified. And while they're looking for a residency, so people could kind of utilize their skills somehow and learn from a physician, and then ultimately either become competitive for residency or maybe continue to do this work if they wanted to do it and work with the community. So this was also allowed IMGs to work in different state facilities like the Department of Corrections, the Department of Social Services, public health entities, and the goal for this was to increase access and to diversify the physician workforce as well. And we also have a federal bill that was introduced last year, I think so, by Representative Adam Smith, that provided much more funding for these kind of works to help IMGs with professional mentorship and other resources. Well, that has not went through, but we're hoping that could go through one day as well. And so this was passed last year, and currently we have 10 IMGs serving around 20,000 people. So they have a 2,000 panel. They're mainly working in geriatric medicine, family medicine, and internal medicine. So we're trying to get more people into this route as well. So next slide. So if you can learn more about this International Medical Graduate Clinical Experience License on the Washington Medical Commission website, which is our medical board in Washington State. And these are the requirements. They have to be a Washington State resident for a year. They have to be ECFG certified and pass all the USMLE steps to qualify for this license. And I think so that's all the slides I had. Thank you so much. And I look forward to discussing more with everybody on this panel. Thank you.
Thank you so much, Mohammed. Thank you all for your remarks. At this point, I'm going to introduce to you Sally Sutton, who's going to bring in some other speakers, and we will have time for Q&A later. Sally Sutton is the program coordinator of the New Maynard's Resource Center and Portland Adult Education. Since 2013, Sally Sutton has served as the program coordinator of the New Maynard's Resource Center at Portland Adult Ed. The purpose of the program is to assist Maine's foreign trained skilled professionals as they pursue their professional careers. In 2015, the New Maynard's Resource Center became affiliated with the Welcome Back Initiative, a nationally recognized model with 11 centers in 9 states, primarily focusing on health professionals. In 2016, Ms. Sutton was invited to participate in the White House National Skills and Credentials Institute. And prior to her current position, she worked as the senior policy analyst at the Muskie School of Public Service at USM, with a focus on healthcare, workforce issues, and public health. Her work included serving as project director for the Maine Health Workforce Forum, whose purpose was to coordinate information and stakeholders to address the state's health workforce needs. Ms. Sutton has been very active in Maine's nonprofit and social justice community for many, many years. And a major accomplishment of her career is that she served as the executive director of the ACLU of Maine for 18 years. She has her master's in public policy and administration and a master's in social work, both from the University of Wisconsin-Madison. So Sally, you're going to take it away with your speakers and then allow for Q&A for our wonderful initial speakers. So thank you so much.
Yes, hi, thank you, Julian. And thank you everyone for taking the time to attend today. And I just want to apologize to some of you who are entering a little bit late and for the glitch that we had with Zoom, but everything can't go perfectly, right? So I don't want to take much time now and just get right to introducing the speakers that we have for this next panel. I'm very pleased to, well, actually first, yes, let me just give a definition about who it is that we're talking about in terms of the work that we're trying to do. And Vanessa has just put up a slide for this. And this definition actually comes from the Hanley Leadership Development Group, which studied this issue as part of their program this past spring. And so we're talking about foreign trained physicians who are individuals who've completed medical school outside of the United States, and they've also met whatever the licensing requirements that they have in their country, and they've also been practicing medicine in a particular specialty for a long time. So they've been licensed practicing physicians before coming here. The other issue that I think we need to pay attention to in Maine, which may be a little bit different than some other states, is that we have a high number of refugees and asylum seekers here that because of their immigration status, we have more challenging issues in terms of their ability to move forward with pursuing their careers. So, all right, so with that, I'll just go to the speakers. So our first speaker today is Jose Ramon Fernandez Pena. He's the founder and executive director of the Welcome Back Initiative. He's also a past president of the APHA. Jose Ramon was originally trained as a physician in Mexico, and he's been at the forefront of immigrant inclusion in the US. He founded the Welcome Back Initiative in 2001 with a center in San Francisco, and now it's made up of 11 programs across the country, including Maine. The Welcome Back Initiative has been helping foreign trained health professionals living in the US integrate into the US healthcare system. And I'll just say, I'm very pleased that Jose Ramon is able to join us today as being one of the Welcome Back Center directors. I can speak for all of us that he's essentially a hero out there for us and our fearless leader. So for him to come and join us today, I feel that we're very lucky. The other next person on the panel is Susan Bell. She's a professor of sociology in the Department of Sociology, College of Arts and Sciences at Drexel University, where she is also a faculty affiliate at the Center for Science, Technology, and Society and the Urban Health Collaborative. She published an article in 2021 based on research she did with Lillian Walkover that focused on the case for refugee physicians, forced migration of international medical graduates in the 21st century, that was published in Social Science and Medicine. And she is working on a second article about women refugee physicians. She is currently writing a book about outpatient hospital care for immigrant and refugee patients in Maine, tentatively titled Permeable Hospitals. And I'll just say a note, Susan has Maine connections. She comes back here in the summer. And when I was working at the Muskie Institute, she was also involved in the Health Workforce Forum work. And we're very interested in having you all hear about the research that she's done. And then Georges Kanda is the next panel person. He is currently the Director of Clinical Services at Greater Portland Health. He received his MD at the University of Mujai Mai in Kinshasa, Democratic Republic of Congo, and is currently working on his master's in public health at the University of Southern Maine. And as I mentioned before, he was part of a group that from the Hanley Leadership Development that had decided they wanted to look at the issues of foreign trained professionals, foreign trained physicians in Maine. And I think that sort of kicked off a lot of the efforts that Hanley had done during this past year at their annual meeting and then co-hosting this session with us. So I want to say thank you to Georges for that and to his leadership group. And with that, I'll turn it over to Jose Ramon.
Good morning, everybody. Thank you, Sally, for the super generous introduction. I think that as we embark in this kind of work or in this kind of effort to understand the value and the importance of integrating foreign trained health professionals, specifically physicians, into the US health workforce, it's important to understand why this is important. And I'll speak a little bit about my personal experience as a foreign trained physician that was trained in Mexico, then did some additional training in Spain and came to the US not thinking I would want to relicense as a physician and focusing more on a career in public health and administration. But when I asked the question, how do you do this? It was very hard for me to find the answers and to find the guidance. And of course, this is almost 40 years ago, before all the tools we have today to access information. But I think there's a number of reasons to be mindful of. One is, I think, the basic moral grounding of the work that we do. And if this country is essentially founded on the promise of being a land of opportunity and was essentially founded by immigrants and of course the people that were already here, and you know what happened. But it's important to recognize that people don't wake up one morning and say, oh, today I'm going to go to the United States and rekindle my professional life because I have nothing better to do. People are coming under duress pretty much always. And every individual that comes to our doors and to our services has a story, usually a sad story that involves loss, that involves tragedy, that involves humanness. And I think we have an obligation to lend a hand to help the people that are coming behind us, just like our people were helped by somebody before. That's my high moral ground speech. But also I invite us to look at the lack of diversity in the US health workforce and what that means in terms of health outcomes, especially for underserved communities. And when I tell you that right now the population of the United States, for example, 18% of the US population is Latino, and 4% of the US physicians are Latino. If we talk about Black individuals, they represent 13% of the US population, but only 1% of the dentists in the country, or 5% of the doctors in the country. And we can go on and on through each ethnic and cultural group. And when we look at the health outcomes in those communities, especially in terms of primary care outcomes, in terms of infant mortality rate, in terms of the prevalence or incidence of things from COVID to HIV, to cancer, to pulmonary disease and heart disease, those are much more, in many cases, much more prevalent in these so-called underserved communities, marginalized communities, or communities that have been historically kept out of services and programs. So the opportunity that these individuals who come to the United States and have been trained overseas and have, in many cases, years of experience in their field to infuse our health workforce not only with their skills and knowledge or their perspective or their take on how to address things, but the cultural and linguistic parity they bring to work with populations for which we're not as effective working. In some cases, we're able to have interpreters, excuse me, but in many cases we are not. So this is what the Migration Policy Institute began to call the brain waste, the concept of we have these assets, these community assets here that are willing and able to become workers to serve populations in need. So that connection, that bridge between the need and the have is an opportunity that frankly, it makes no sense to pass on. Moreover, if we look not only at the number of vacancies and unfilled spots across the country, especially in rural areas, and the maldistribution of health professionals all over the country, it's an opportunity to fill gaps. If I always like to say this, the Welcome Back Initiative in its 22 years of existence has worked with approximately 23,000 people from 168 countries. If I had a magic wand right now and turned every one of those persons back into the profession they held in their country of training or their country of origin, there will still be thousands of vacancies in the US health workforce. So none of these individuals are going to take jobs away from anybody. So dismissing those myths, I think, is an important. And I also wanted to touch briefly on the comment that I'm going to forget your name, Dr. Keefe. Is it Keefe? I believe it is. And not forgive me. You work with a medical board of
Dr.
Maine.
Steele.
Dr. Steele, maybe?
Yes, I'm sorry.
No problem.
The point that you made is incredibly important. We try in our work to ensure that the people we work with meet the licensure standards. We're not challenging licensing standards, and we're grateful for medical boards like yours in Maine that understands this and that is willing to work in the kind of work that we do. The one question we may have at some point is, are the standards for acceptance or foreign credentials, can we do it in some other way besides the way we're doing it now? So it's not changing the standards or lowering the standards, it's figuring how do we assess competency? And can we do that in such a way that builds on our participants' knowledge and experience? I'll say if anybody who tried to give me a medical license today after 40 years of being out of practice, I would put him in jail because I should not be licensed to do anything medically. But there's individuals who have been here 1 year, 2 years, 5 months, 3 years, 6 months, 6 years that are perfectly capable of demonstrating their competency. And we have a case in the past couple of years, and perhaps Mike Zimmer will touch on this in a moment, is during the pandemic in a number of states, we were able to obtain temporary licenses for foreign trained professionals so they could help the local workforces in Colorado and I'm going to block all the states where that happened right now. But in many of those cases, these individuals were granted those temporary licenses. They were able to work effectively and productively under the supervision of a clinician. And there was not one bad outcome. Nobody died, nobody was killed, there was no incidence of malpractice. And yet these individuals' licenses have now been revoked. So I think there's an opportunity to think creatively on how can we build on our participants' assets and training and facilitate through a rigorous measure of quality for permanent licenses across the country. So I think I'm gonna stop right now and turn it back to Sally. Thank you very much.
Okay, thank you, Jose Ramon. We'll go to Susan Bell next, and we'll save questions for the end of this panel. So Susan, and Vanessa has some slides for you.
Yes, thank you. You can put the first slide on, which is just a title slide. And I am so happy to be back in Maine, even though it's just virtually. I taught at Bowdoin College for 30 years and came to Philadelphia in 2015. And I am just so happy that Maine is moving forward with this initiative and honored and pleased to be part of it. Now, I'm quite sure that many of you won't, my mandate is to give you an overview of foreign trained physicians, a kind of big picture, and to report briefly from my study. So that's what I'm going to do. I'm sure that you won't be surprised to learn that approximately 1/4 of all practicing physicians in the United States went to medical schools outside the United States. And to put this numerically, in 2020, there were just over 1 million licensed physicians in the US. I'm gonna hold off on, I'm not gonna talk about this slide quite yet. And 783,639 of those approximately 1 million physicians graduated from US or Canadian medical schools, and 233,177 graduated from 2,200 medical schools in 169 countries. The first large-scale migration of foreign-trained physicians began in the 1960s. So we need to look back to that period 60 years ago. And the first large-scale migration of foreign-trained physicians was in the wake of the implementation of Medicare and Medicaid insurance, which gave access to medical services to millions of Americans who could not afford to pay for medical care and who now could use public funds to access medical care. And that, combined with population growth, resulted in a physician shortage. The Immigration and National Act of 1965 included a special skills exemption to attract physicians from abroad to staff hospitals in low-income and underserved communities in exchange for legal status. The legislation was accompanied by mass recruitment of foreign medical graduates from predominantly post-colonial Asian nations at the time. And although this was envisioned as a short-term solution to a problem in the 1960s, This arrangement is now embedded in US medicine. And now for the next slide. Physicians that graduated from medical schools outside the US are called foreign trained physicians or international medical graduates, and there's a lot of slippage between these terms. For purposes of US medical licensure qualifications and record keeping by the AAMC, the American Medical Association, and the Federation of State Medical Boards, all foreign medical graduates are lumped together. But there are important differences among them, some of which have been described and named already. US citizen IMGs go to medical school outside the US, typically to Caribbean medical schools, often because they're not admitted to or cannot afford the cost of going to a US medical school. Non-US citizens who prepare to complete their medical training in a US residency with a J1 or HB1 visa, and non-US citizens who are compelled to flee from their homelands or refugee physicians. In other words, there are three categories of foreign trained physicians, and today I'll provide an overview of the non-US citizen foreign trained physicians, summarize differences among them, and then reflect on lessons for Maine from my study of refugee physicians. The next slide. Now, this is a very condensed version of what you've already seen, these pathways. But here's the important point I want to make, that no matter where a non-US IMG attended medical school, what their specialty is, how many years of experience they've had, or what kind of patients they've cared for, none of them may practice medicine in the United States until they've earned a US medical license, with very few exceptions. And Dr. Fernandez Pena has referred to one, which is being able to be supervised by another physician. And this is a long and expensive process. The education must be certified by the ECFMG. They must pass the US medical licensure exam and complete a US medical residency program. And the amount of time it takes depends on many factors, including English proficiency, specialty, number of years since graduation from medical school, the ability to study full-time for an extended period, and for many, the effects of violence and war. Competition for these residency spots is fierce, and gaining admission to a residency is a key bottleneck in the licensure process for non-US foreign trained physicians. Although there are no formal regulations that require residency programs to favor physicians who graduate from medical schools in the United States, graduates from medical school in the United States are more likely to match to a residency than international medical graduates. In 2022, 92.9% of seniors in US medical schools were accepted into a medical residency program, compared with 58.1% of non-US citizen international medical graduates. Many refugee physicians have been unable to win a residency despite completing the required credential verification and examination. Matching requires strong social networks. To help prepare for residency and strengthen their chances of matching, many non-US IMGs complete observerships, internships, and/or research experiences. In addition to providing firsthand experience in US healthcare settings, these opportunities help non-US IMGs connect with US physicians who can then write letters of recommendation on their behalf. Although the completion of an observership is not mandatory for residency admission, 90% of non-US IMGs complete some type of US-based clinical experience before successfully matching to a residency. Becoming a licensed physician for non-US IMG for non-US IMG physicians entails, and this is important, as you've already heard, it entails successfully navigating the institutionalized systems of medical licensure and of migration. By crossing national borders, all non-US international medical graduates are dependent on securing visas or achieving refugee status before entering the US or applying for asylum after they arrive. And this requirement limits their mobility before and after migration. And although the focus here is really in Maine is primarily on those who enter the US because of forced migration, I just want to point out that the most visible group of non-US citizen foreign trained physicians pass through the immigration system and enter the US with a visa. The J-1 visa was established as the most common one, and it was established under the Fulbright-Hays Act of 1961 for a visiting scholar program that would allow foreign nationals to live in the US temporarily, participate in a variety of education and training programs, and promote cultural exchange between the US and other nations, and strengthen the ties that unite us across borders. Today, there are many different categories of people that can be issued J-1 visas, from au pairs to camp counselors to government visitors and secondary students and foreign trained physicians. And as you've heard, the Educational Commission for Foreign Medical Graduates administers the J-1 program for physicians. So all foreign trained physicians pass through the ECFMG to get their J-1 visa. And after completing their training, those with a J-1 visa must return for 2 years to their home country unless they secure a waiver. Note that these physicians complete their training in the United States. And there's much research about the pathways and outcomes of these non-US citizens, much more than there is about refugee physicians. Although most studies, even of all foreign medical graduates, have not included unsuccessful applicants in their research. My research is among a small but growing body of literature about refugee physicians, a group of foreign trained physicians that remains almost invisible in national statistics, social science research, and discussions. This is particularly relevant to Maine, this group. My research focuses on refugee physicians, that is, people who were forced to leave their homelands. Many of them did not plan to leave. Many completed their medical training, were licensed, and practiced medicine in hospitals and clinics before they fled to the United States. In my study, more than 2/3 of the physicians fled their home country because of violence, imprisonment, threats to safety caused by political or religious beliefs, or to avoid unstable political climates. Their experiences of forced migration are intertwined with their experiences as physicians. They reported that their immigration status was an important factor in their application for medical residency. Asylum seekers or physicians without permanent resident status faced almost insurmountable barriers to their applications. The time and money required to prepare a strong application to a medical residency is compounded by the time, money, and paperwork required by the US immigration system. The longer it takes to achieve asylum or permanent resident status, the more time elapses from the date of medical school graduation. The more time that elapses, the less competitive a candidate's application to a residency will be. For example, applying to a residency more than 5 years after graduating from medical school is much less likely to result in a successful application. And many of the physicians in my study had graduated medical school more than 5 years after they arrived in the United States. It's extremely difficult to persist along the pathway to US medical licensure in the face of such uncertainty. And I'd just like to talk for a minute about refugee status, since that's so relevant for many of the physicians in Maine and for foreign trained physicians who are trying to become licensed. Refugee status was established by the Allied powers in the 1951 Convention relating to the status of refugees to govern international mobility. To be granted refugee status, people request it from outside their country of origin, and after it's granted, people are protected from being returned to their country of origin. However, less than 1% of refugees are resettled every year. Most refugees are never resettled, they're just in that status, and they're not returned to their country of origin. If refugees are assigned for resettlement, they then travel to the country where they will resettle and become eligible for citizenship. Some people identify as refugees when in fact they inhabit a different legal category, such as asylum seeker. And asylum seekers petition a government for asylum after they arrive in a destination country, and their requests for sanctuary are evaluated by national asylum systems. And in Maine and in my study, there are people in both of those categories. On one hand, refugees but they identify many of them themselves as refugees. In my study, I now note that with these statuses, some people are coming with a visa to the United States with a J-1 visa, and they're finishing their medical training. Others are coming to the United States because they've been forced to leave their home countries after they've completed their medical training. And in all cases, they go through both of these systems of licensure and immigration. In my study, I conducted qualitative interviews with 28 refugee physicians in 2019. All of them self-defined as refugees, asylees, or asylum seekers, and were trained outside of the US. I interviewed them, and the interview guide focused on their education, professional identities, work before and after arriving in the US, and events and experiences of leaving their homelands and resettling. And you can go to the next slide. And this is a picture of the physicians, and note that of the 28, they graduated from medical school anytime between 1997 and 2018. Their progress on US medical licensure, 4 of them were no longer pursuing a US medical license, 7 of them were studying for the USMLE. 17 of them had been certified by the ECFMG. Of the 17, 15 had applied to match to residency. 7 of them matched, 8 did not match. So roughly half of the people who applied to residency were accepted into residency, and 2 had not. The average years it took them to get to the residency match for those of them who were successful was 6 years. Common themes across the flight biographies that were consequential for success into matching into a US medical residency program were progress on certification by the ECFMG, clinical experience in the United States, and years since graduation from medical school. Most of the physicians had not begun the process of becoming certified by the ECFMG before arriving in the US. Of those who'd gained US clinical experience at the time of the interview, 13 had no US clinical experience when they fled from their countries of origin. These physicians arranged for and completed observerships or clinical rotations in the US after arriving. The other 7 traveled to the US for observerships while in medical school in their country of origin. 6 of them were from Turkey. Roughly half of the participants fled within 5 years of graduating from medical school, while the rest fled many years after. All 7 participants who applied and matched are men from the Middle East. Of the 8 participants who applied to match and did not match, 6 were women and 2 were men. And the paper I'm working on now explores why it is that none of the women who applied to a US medical residency matched to a residency program. My research echoes and gives details about the creative and strategic efforts foreign trained physicians make to become licensed again. As sobering as the results are, they also suggest ways to open up the pathway, reduce brain waste, and benefit individual foreign trained physicians and the communities in which they have resettled, including in Maine. What Jean Batalova and Michael Fix write from the Migration Policy Institute in a 2022 report from the called Leveraging the Skills of Immigrant Health Professionals. First, the lack of recognition of foreign education and work experiences remains a major barrier to immigrants' labor market integration. Second, my research echoes their report that internationally educated immigrants and refugees often find it difficult to restart their careers in health and medicine. Among key obstacles to the labor market integration are lack of foreign credential recognition, licensing barriers, and limited professional networks. Third, unauthorized immigrant professionals and those who came to the United States as humanitarian migrants, as Batalova and Fix write, that is, refugees, asylees, or those on special immigrant visas from Iraq and Afghanistan, face greater obstacles in finding jobs corresponding to their levels of education and skills. The American Medical Association of Medical Colleges estimates that the US experienced a shortage of more than 20,000 physicians in 2017 and predicts this will grow to a shortage of between roughly 42,000 and 121,000 physicians by 2032. Shortages are especially acute in some specialties and in some geographical areas of the US. Studies show that international medical graduates are likely to be working in specialties that are less popular, in geographical locations that are less desirable, and with underserved population, precisely the specialties and the populations for which there's the greatest shortage in the United States. They come from diverse cultural and linguistic backgrounds, equipping them to provide culturally and linguistically competent care for an increasingly diverse patient population in the US. Many of them bring clinical experience with them to the US. They're more likely to be in primary care, to be in less popular or prestigious specialties, in less desirable geographical locations, with underserved populations, and many acknowledge their work in the safety net as a transactional cost of living and working as physicians in the US. By early spring 2020, during the COVID-19 pandemic, the need for physicians had become so acute that governors and health officials called on retired physicians to return to work. Many states loosened licensing restrictions and waived licensing fees, and the Federation of State Medical Boards gave free access to its database to strengthen the verification process. A year ago, in February 2022, the president of the Association of American Medical Colleges, David Skorton, testified before the House Judiciary Committee on Immigration and Citizenship. And he said, quote, simply put, we need more doctors from everywhere, unquote. And I think this forum is perfectly timed to capitalize on that need. Thank you.
Okay, thank you, Susan. And we're now going to turn to Georges. I don't believe you have any slides. I don't see you on my panel yet. Are you there? Georges?
Say, Sally, I'm unable to spotlight George's for some reason.
Okay, I don't see him I don't see him signed on.
I see him
So
in
he's
the
coming.
list. He doesn't have his mic on and he doesn't have his camera on, but his phone is here.
That's why I can't spotlight him. Okay.
Okay, so how do we get him to participate?
George, can you unmute yourself, please?
I just sent a request to unmute him.
Thank you.
Okay, while we're waiting for him to join us, I'll explain what's happening. Next, he'll do his presentation and then we'll have some questions. And then we'll go into breakout rooms. So we're sort of going from the higher level presentations to having you all have opportunities to meet and talk to individual physicians. And then after the breakout rooms and those will be facilitated discussions. Then after the breakout rooms, we'll go into a break for all of us, and then we'll come back for another panel. I think I'm going to, just so we can keep things moving along while we wait for him to figure out how to join us. We have a couple of questions here that I want to get to while we're waiting for him. There was one, and this actually goes to Mohammed. So again, as we think about questions, it can be for this panel that has just talked and also for our introductory speakers. So the question for Mohammed is, in Washington, can foreign medical graduates sit for USMLE 3 without doing another USA residency or only after completing that? So Mohammed, that's to you.
Yeah, so they can sit for all the USMLE exams even before they start a residency training. Actually, US medical students cannot sit for the USMLE Step 3 until they're in residency, but IMGs can sit for Step 3 even before residency training. So a lot of people actually do the Step 3 so they can be more competitive for residency training.
Okay, thank you. And then there was another question, and maybe this one goes to Susan. How are you defining clinical experience? Would working under a different license, such as a paramedic or CNA or nursing, count as clinical experience, or is there a specific clinical training that international health professionals need to access?
Yeah, this is a great question. And I did say something about it in the chat, but the clinical experience that somebody had overseas doesn't count. And this is specifically for physicians. So if you have experience in a different profession, it's not going to count. What's important is to have some kind of experience. I'm going to leave out the clinical for the moment in the US healthcare system. And it's not, and the way it's typically used is through either having shadowing or literally participating in a so-called observership. And there are guidelines for observerships where somebody is under the supervision, and here I'm talking about a physician, a foreign trained physician, is under the supervision of a physician in the United States who is doing clinical work. And that physician is learning how the e-record system works, how medical technologies work in the US by being in a clinic somewhere, not being able to practice medicine, but having some opportunity to observe medicine in action in the United States. And although there are guidelines, there's a very wide range of what these observerships are and how much they cost and how much time somebody would spend in them. But they serve several purposes. And a very important one is introducing a foreign trained physician to one or more US physicians who then can potentially support them in letters of recommendation for their applications for residency, as well as helping to familiarize them with what it means to practice medicine in the US. In my study, essentially everybody said the clinical skills of being a doctor, the actual doing of medicine, don't change no matter where you are. What does change is the system in which you're working. And what the observerships do is to give somebody clinical experience in US medicine. And it's not the same as you would have in a residency program itself, where you're actually interacting with and doing medicine. It gives you some kind of experience in understanding what it means to do the work that you've done before, but to do it in the setting of the United States.
Okay, thank you, Susan. I think Georges is back and we'll turn it over to him now.
Good
Yay,
morning.
you're there. Okay, great.
Okay.
Take it away.
Good morning, and sorry for I was dealing with some emergency here. So my name is George. I'm a Director of Clinical Services at Greater Poland Health. I'm a foreign-born physician from the Democratic Republic of Congo. I've been in the US now. It has been for 4 years, almost 5 years now. So this is a great opportunity for all foreign-born physicians to meet and this platform on Zoom, have this really nice conversation or discussion. So we've been trying, people came before me in the US and even myself, we've been trying to integrate the system, the medical system in the US, but we found out that the system is really, really tough for us. But we are not giving up. We're still trying so hard to be part and to integrate the system. So, excuse me, I would just say it's kind of frustrating going to school, doing the med school for like 8 years and come to the US, not having the opportunity to work as a physician. We know that science is the same everywhere, the human body is the same, so nothing's different from, I mean, there is no difference between countries. So we've been asking ourselves question why we are now practicing as a physician. Among all the foreign-born physicians in the US here, they are well-trained, myself included. We are really well-trained and we are able to do the job. So we found a difficulty to integrate the system. There is a USMLE, which takes really time, kind of 5 years to go through the process and finish that process and integrate, to start being doing an internship, which takes really time. But if the MIRAV or the organization can put something down, like, okay, for foreign physician, we give you an opportunity to kind of follow up one physician for this period of time. And then after that period of time, we can maybe take an exam, a license exam. If someone passed to that exam, that's fine. If he failed with the exam, that's also fine, but at least he tried to integrate. I've been telling my friend, we came in the US, in the US, most of the people, they asking us to go do the DSP job, which is not bad because we are taking care of people. But let's say that an American physician traveled around the world, they go to in Europe, in Africa, in Iraq. Does he going to work as a DSP? That's the big question that we've been asking ourselves every day. You'll be working as a physician. Why, when foreign-born physicians come to the US, they are not practicing. They're treating them as nothing, which is not really fair for us. Can we come up with a system like, okay, what do you guys want? Maybe, okay, you want to work as a physician assistant? We have this process we can give you this pathway. You can start doing this and become a physician, because we want to restart, we want to gain our license, working as a physician, or at least being close to the physician in the US. So I know that this is a good opportunity. There is a very important person in this meeting. If you can really, really care about us, because this is kind of wasting the skills in the US. There is a lot of foreign physicians, but we are not utilize them. And there is a shortage, a big shortage. Especially in Maine, there is a big shortage of physicians. There is a big shortage of nurses. There is a big shortage of physician assistants. But there is physician well-trained, not doing anything. So why are we wasting time to take care of those people and start helping the community in the Maine? So it's just briefly something that I want to share with you, if it might help, to give us the opportunity to work as a physician, work as a physician assistant. That will really help our community, and then that will help us as well. Thank you.
Thank you for those comments. We have time maybe for 2 or 3 questions, and then we'll go into breakout. I think we're pretty much on schedule still, even with the few bumps that we have. There's one question in the chat that I'll read from Joy Gould, and then others, you can either raise your hand or put something in the chat. But again, we're trying to wrap this up with maybe just 2 or 3 questions. So Joy's question is, she's worked with foreign trained physicians who went through US Maine-based CNA medical assistant training so they could work while also trying to attain their license. Some have gone through nursing school as a path to employment in the field they love. Often they have families to support and need to work and may not be able to afford an unpaid shadow. I'm wondering how to best parlay that clinical experience working in the US. It would introduce them to medical records, US health system. So I'm just throwing this out for any of the panel people who want to answer it.
So, for example, in the Welcome Back initiative, we see this is the typical participant we see with this kind of background. And when we start working with them, after initial assessment, we try to set with them short, mid, and long-term goals. So while the long-term goal is to practice medicine, the initial goals may be as simple or as complicated as trying to get their transcripts out of the country of origin, or to improve their command of the English language. So there's a series of initial steps that we can't forget. And secondly, when they're driving Uber or they're working at McDonald's, a first step could be to guide them to a phlebotomy program at the local community college. So they start working at the clinic down the street and acquiring some knowledge of what's happening. What's that red box hanging from the wall? What do they call the EMR? Why does a nurse call the doctor by his first name? Whatever it is. And begin that kind of developing a knowledge of the workplace, the rules and regulation, developing a reputation for being, prompt, responsible, polite to the patients, all the things that eventually down the line are going to build those letters of reference that we don't talk enough about, but a key piece of accessing residency training is a letter or a series of letters of reference from US-based clinicians, physicians. My letter from Mexico from Dr. Gonzalez is going to do nothing in my application to a residency training in the US. So it's that it doesn't have to be that they were doing surgery, but it could be that they were, you know, a CNA at some point, or that they did a paramedic training at some point, or that they're doing an EKG tech training or a surgical tech training program that may be short-term trainings and begin to build their capital as professionals in this country to the end of earning those letters of reference.
Okay, Susan, do you want to add anything to that?
I would just say that something that I know that physicians in my study found difficult was that they couldn't translate their training as physicians easily into becoming a nurse or becoming a physician assistant, that they still had to start at the first step, and that for those who've decided they're not going to keep going to try to become physicians again, even moving sideways is a difficult project. And so I think that that's something to keep in mind, is the difficulty of moving into a different health clinical program with the experience and credentials of a physician.
For sure.
Betty, you have your hand up. Go ahead.
Thank you so much. Sorry, I'm at work, that's why. Sorry, I was, and then I have to engage at work again and come back. I was just gonna add to the doctor who speak from Congo, the kind of frustration physician gets when they come here to the United States and they are well trained, working well at home. My point of view is like, if there is a way, because like if you come from there and you have graduated kind of like long time ago, it's difficult to get into the system here as well. It's like that's one of the boundaries as well. Like I know a lot of good doctors, good specialists who were back home. I'm from Sudan. So they came here. Sometimes they're working with me here. All of us are working as interpreters. And sometimes they know more even than the physician who's working. They will assist the physician in a lot of things, despite they are just working as interpreters, as myself, right? But like they have that knowledge. As he said, human beings are the same human beings, and medicine is medicine. Not all of the foreign trained doctors who are coming here are like different languages. They learn. Most of them are learning medicine in English, not in different languages. So they already have the knowledge in English itself. So my point here is I'm talking about Maine because you cannot change anything outside. If you guys who are responsible of the medical issues or whatever it is in Maine, look into it. Like when a foreign doctor comes, look at the experience of that doctor, and at the same time, let there be another program so you can be like the leading state in this thing. Like being like the doctor can come, the physician can come from the different country, get trained in the system, like being at the hospital, maybe let us say for 2 years, if that's okay with you. And he will learn the system, how the system works. Even if that's a nurse, she can learn the system. And you can even evaluate, because every doctor who comes here evaluate the certificate, and they tell them, yes, you are a doctor. So when that person did that, because the communication with the university they came from or they graduated from, the SEL or the ELS, I don't know, I just don't remember the abbreviation, which evaluate our certificates when we come to the United States and apply to them. So they know that we are physicians, we got graduated, we worked. So we just need to know the system over here. So if there is a way, because it's really a difficult path, if there is a way, even if it's, you say 3 years, this foreign doctor can be on site, not receiving money, not doing anything, just observing, seeing how the system is working, and then going through the system. And if there is an exam to be done, give that exam to the doctor. He's going to do it. And as he said, he passed the exam, well and good. He doesn't pass the exam, he will try again and try again. That's okay. But at least there's supposed to be a path. I work at MedMed right now as an interpreter. We have shortage in doctors. We have shortage in gynecologists, and we have gynecologists who are work in different countries, in different countries. They're staying here, not working. And it's just so frustrating that you see the system is preventing you to pursue your career as something you love to do. So I'm just, my point here is let us work on getting these physicians into the system by training them on site, and not giving them boundaries not to do it. And at last, then they go doing things that they don't love. And it's all about the passion and the love to the patients. So I think that's my idea, if you guys got my idea. And thank you.
Okay. Thank you, Betty. I think what you're doing is what happens at a lot of meetings is we lay out the problems and people are already trying to move into solutions. So that's a very positive step that you're moving us in. We're going to change up our agenda a little bit. It's taking more time to put people into breakout rooms than we had anticipated. And so we're going to do our break first for 15 minutes, and then we're going to come back and do the breakout rooms. And I saw Mufalo. If you had a quick comment, Mufalo, I can give you a chance for that. And then there's a really good chat going on that I hope people will read and pay attention to, particularly, well, they're just good comments there, and we can try and come back to some of those afterwards. So Mufalo, and then Ghislaine, if it's a quick question, I'll get to you, but we really need to take a break. So Mufalo, go ahead.
No, it's a comment. And in just listening to so far, and I just wanted to piggyback on what, Dr. Betty just mentioned. A quote, just comes to mind that I just heard recently from a very wise man, and it kind of just puts what Betty, just talked about. As immigrants, we are educated out of our context to understand your context. Immigrants are educated out of their context to understand your context. What that means is, when I was in my country, I learned everything about the American system. When we come here, we just connect, oh, this is what that is. What we are taught, we're not taught in our African setting, and I'm speaking as an African. I wasn't taught in my Zambia nest. I was taught in a foreign place. So we understand your context way before we come to your country. So when we come to your country, if you put us if you put me in my field, if you just put me there, I can relate, because I was taught your language, I was taught your system, I was taught your history. What I just need a refresher technologically, where you are, as an institution, how far you've gone. I just need a refresher course, and everything aligns. For medical, You're talking about somebody has started a body. It's the same body that they started in Africa, in Asia. They just need to know the system. So I just, in hearing Betty, that quote came to mind because it was so profound, and I've never really thought about it until I heard that quote to say, I was definitely educated out of my context to understand a foreign system's context.
Okay, thank you, Mafala. I'm going to leave it at that. I'm going to ask people to please read all the good comments that are in the chat. We're going to take a 15-minute break, and then when you come back, you'll be put into breakout rooms. So actually, we come back at 10:45. So thank you, everyone, for sitting through this so far, and thanks to our speakers.
So we are going to go right into the next panel. And I just want to say there's probably so much more information that we can cover here. The goal was just to have an overview and kind of talk about some next steps that are going to be taking. So, and again, some of us will be available after the program ends. So I want to just welcome back to the second part of our program. My name is Vanessa Sylvester. I work at the New Manor Resource Center. And I am hoping that this panel, or I know this panel, will provide information on the progress that's happening in other states to provide opportunities for foreign trained and foreign credentialed positions. So I just want to share the folks that are going to be speaking on the panel, and I'll introduce everybody together, and then we can kind of go from there. So Michael Zimmer is a senior policy advisor at WES, World Education Services. He is recognized as a national expert on licensing and has previously served as the cabinet director for Governor Rick Schneider of Michigan. Among other positions, he has been the director of the Michigan Department of Licensing and Regulatory Affairs and the executive director of the Michigan Administrative Hearing System. And he will be talking about the overview of some of the work nationally. Amy Grunder is the Director of Legislative Affairs from the Massachusetts Immigration and Refugee Advocacy Coalition. Amy brings broad experience in law, human rights advocacy, and communications to her role. As the Director of Legislative Affairs, she leads the legislative advocacy for the state's the Safe Communities Act and other state legislation promoting immigrant rights, education, health, and safety. And finally, we have Dr. Robert Marlin, who is board certified in internal medicine. Dr. Martin is at the Lowell Community Health Center and serves as the chief of the Meta Health Center, which focuses on refugee health. He also previously served as the chief of the Department of Family Medicine. Robert was appointed to the Massachusetts Special Commission on Foreign Trained Medical Professionals, which issued a report July 2022. And then we will have Muhammad also available from before during the questions and answers. So what I would like to do is turn the panel over to Michael Zimmer.
Well, thank you, Vanessa. And I'm very, very happy to be here. We've done a lot of great work in Maine, and this is a very, very positive set. And thank you, Sally, for setting this up. World Education Services is a nonprofit social enterprise dedicated to helping internationally trained and educated professionals achieve their educational and career goals in the United States. We've been in existence for about 45 years. Working primarily at the beginning in credential evaluation and then through the Global Talent Bridge, working more on advocacy with the states. We currently work in about 20 different states, including Maine. I'm going to go a little bit quickly through skills underutilization, but I think a lot of people have already covered that. And then we'll go to barriers and state models that you may want to look at. The Impact Migration Policy Institute, I'm sure you're all familiar with they and their wonderful work. They estimate that there's 2+ million immigrants and refugees with college degrees that are currently underemployed or unemployed, resulting in a net loss of income to those individuals as well as unrealized taxes annually. The key barriers that we've found in other states, it sounds like you guys are finding in Maine: limited English proficiency, inadequate recognition of international credentials and experience, confusing requirements and complex regulatory and licensing schemes, and a lack of regulatory focus and direct opportunities. I want to focus a little bit on what's going on in the other states with international medical graduates. Am I breaking up? I'm sorry, I just saw a message that said I sounded like I'm breaking up. If I am, please tell me. I'm going to defer the incredibly great progress in Massachusetts for Rob and Amy to talk about, but I'm going to go quickly through some of the bills that have been going on in other states in the last couple of years. First, at least one of my breakouts, we talked about faculty licensing. Arkansas had a very good faculty licensing bill, Senate Bill 456, that was enacted back in 2019, that expands the use of academic licensing under the supervision of a fully licensed faculty member. And at the end of the period, which is typically 2 years, the faculty license candidate is eligible for full licensure outside of the university. So that's a new pathway that they're really pushing the envelope in Arkansas. Colorado, many of you may have heard, has probably been the most expansive IMG legislation passed to date. Does three things really. First, it grants international medical graduates who have been previously licensed and previously practicing access to the state's physician reentry program. For those of you that are familiar with that, that is typically present in most states for licensed physicians who simply retire, but then they decide they want to come back. By making internationally medical graduates eligible for that, that opens up a new avenue for IMGs with previous license histories not to go through and have to secure another residency before they're licensed. The other two things they did is the bill lifts from a very successful Minnesota program, one of which does physician readiness and a clinical hours, a paid clinical hours program, which in our earlier conversation, we talked about that being a significant barrier for IMGs finding US approved clinical hours. IMG has a paid program to pay for it. And they also have a state paid residency slot. Last year, there were 2 dedicated to IMGs. Massachusetts, we'll let Amy and Rob talk about an amazing progress they've made. I will probably talk a little bit about it, Amy, just as an excellent model to look at. Sorry. Washington, Mohammed talked about this earlier, Senate Bill 1129, sort of the first out of the gate, and congratulations to Mohammed for leading the challenge on this. The first sort of bill to deal with this allows a limited license, 2-year limited license under supervision, renewable once, requiring the IMG to work under the supervision of fully licensed during that period. I think you will see in the coming months legislation introduced in 3 or 4 states dealing with IMGs, probably Arizona, I would imagine Wisconsin, probably Utah. A lot of states are looking at this. Those states that are looking at IMGs, particularly creating alternate pathways for those that are previously licensed, there's a bunch of decision points that Maine will have to also look at. What's the required length of prior licensure? What's the testing cadence with the USMLEs? How do they do credential evaluations? Is there a license look back? How old can the license be? Entry point, a lot of States that are looking at this are having the entry point as the hiring agency, not necessarily the licensing board. What's the length of the supervision period? Is there a service requirement, and what practice hours does it cover? I want to talk for just a minute about some things that happened as a result of COVID. Somebody mentioned this earlier. A lot of governors took sort of extraordinary measures to make use of the IMG population in response to COVID. Nevada had quite a few interesting programs that required the state's medical examiner to do the credential evaluation to allow licensure. New Jersey did, Illinois has a proclamation on this. Michigan had an EO, a lot of EOs. And what the EOs proved more than anything is that the IMG population is substantial and it's real. In New Jersey, for example, under their EO for temporary licensure, they had over 1,000 applicants for that from all over the United States. Under the Illinois proclamation, which was much more recent, they had 400 applications. I want to shift gears a little bit. There are three other avenues that states are looking at generally, not specific to IMGs, that may be something that Maine wants to look at. And these are primarily avenues right now that are not open to IMGs, even under the states that are looking at it, but it's an alternative. Maine, through LD 149, which was, I think, amended by LD 2035. I get confused on how Maine labels their bills. Granted authority to the license director to waive certain requirements and fees as part of the licensing process. Now, right now, LD 149 does not apply to the medical board, but it could be expanded. Vermont, through H427, granted similarly pretty wide discretion to their director to grant licenses to internationally educated using credential evaluation services outside. Again, this would not require residency, would move towards immediate licensure. Again, in Vermont, that doesn't apply to doctors, but it's still a good model. The last one I would point to is Utah, Senate Bill 43, which would make internationally trained individuals eligible for what's known as licensure by endorsement. Right now, if I'm a doctor in New York and I want to practice in Maine, I could get my license endorsed. The legislation in Utah would make internationally educated eligible for that same process. There are a number of bills that are looking at immigration status. I don't know if this is the case in Maine, but what status does one have to apply for licensure as an IMG? That's an issue that the state's going to have to look at. One of the people mentioned in the chat, I noticed, the issue of residency equity, and a lot of states are looking at this, particularly, I believe Illinois is going to have a bill out. In many states, I don't know if this is the case as it is in Maine. The length of the residency for a internationally educated candidate is longer than the length of residency required for a domestically educated. And I don't mean the residency itself is different, but for example, I'm trying to think of the state, New York, I believe, a domestically educated residency candidate or a person in residency can be fully licensed after 2 years. Internationally have to be licensed, can only be licensed under 3. This makes international candidates less attractive for residency programs. I do want to talk a little bit about commissions and study commissions. There are a whole host of states right now that are engaged in commissions and task force looking either at healthcare or IMG specifically. Colorado's great legislation came out of the Nurse Physician Advisory Task Force on Colorado Health. Massachusetts, which I think Amy and Rob are going to talk about, the Specialist Commission on Foreign Trained Medical Professionals. Maryland has a commission to study workforce healthcare, which is just starting. Michigan's task force on foreign trade medical professional licensing has just started. Illinois got one, the task force on internationally trained healthcare providers. That one will be starting, I believe, this month or next. All of these individuals are looking, all these states are looking at how do we create pathways to licensure and increase access to residency for internationally trained medical graduates. If I can do a push on this a little bit, the value of the commissions, particularly as it played out in Massachusetts and Colorado, is by having the entirety of the impacted groups on these commissions, the immigrant communities, the IMGs in the state, the regulatory bodies, the hiring entities, you can develop a reform mechanism that is useful and tailored to that state's needs. The last thing you want to do is create a wonderful reform, go to the time and effort to create a reform that no hiring entity, no hospital, no clinic, no physician group is actually going to use because of a variety of factors. So you want to have everybody involved. And I think at this point, I'm going to turn it over to Rob and Amy to talk about the incredible success in Massachusetts.
Let me just interrupt for 1 second. Could everyone please mute yourselves? Thank you.
All right, thank you, Michael, so much for that. I think Amy.
I think it's Rob.
No, I think.
Okay.
Oh, right, we decided it was going to be me.
Yeah.
Forgive me, sorry, we just decided this.
Massachusetts.
Yes, here we are, Massachusetts in the house. First of all, I want to thank everyone, especially you, Vanessa, for organizing us to come to this conference today, for inviting us, and also everyone here who's really, whose work has really laid the foundation for the work that we're doing here in Massachusetts. My name is Amy Grunder. I direct state policy and legislative affairs at the Massachusetts Immigrant and Refugee Advocacy Coalition. And I'm here mainly to talk about the political process here. So our process, so right now we have just started a new legislative session in Massachusetts. It began in early January. And there's a bill filing deadline that's actually tomorrow for this session. And we are on the point of filing legislation, which for the first time would attempt to create a pathway for internationally trained physicians to practice, to obtain full licensure here in Massachusetts. But if I go back a little bit to start at the beginning, way back in 2014, there was convened a task force on immigration healthcare professionals in Massachusetts that created a report. This was actually authored by Jeff Gross, who many of you may know. He's a senior consultant at Wes and a former colleague of mine at Mira. He authored the report, but he convened a large, like basically every kind of stakeholder you can imagine, to talk more broadly about barriers to licensure and other barriers in addition to licensure for a range of internationally trained healthcare professionals. So not focused on physicians, that focused on policy changes that the Baker administration could make. This was the last, 2014, we're talking about our prior governor, that the Baker administration could make to reduce administrative changes that they could make to reduce barriers to practice, right? Short of licensure, short of changing the law. From there, in 2017, we began at Mira working with legislative allies at the State House to file a bill to create a commission. And that did seem to be a great entry point. We found a couple of really good House and Senate sponsors. And the idea was to create a commission on foreign trained medical professionals, which would include all the stakeholders that would ultimately be the people that would both, as Mike pointed out, both the people who would potentially hire these folks, but also people who would be likely to weigh in with the legislature, and also to train folks, et cetera. So Ultimately, this legislation did not advance in the traditional manner. So the Senate sponsor stuck it into the state budget and it got passed through the state budget in 2019. So that was great. The membership of the commission was outlined, of course, in the legislation, included appointees from all the relevant stakeholders we could think of, including for MIRA, myself, Dr. Rob Marlin, who'll be speaking in a moment, and a Brazilian internationally trained physician, Dr. Lisa Tristan Cheever. Those were the MIRA appointees. We also had the Boston Welcome Back Center, Mass Medical Society, the Mass League of Community Health Centers, the Boston Conference of Teaching Hospitals, UMass Medical School, and representatives of all the boards of registration of medicine, dentistry, nursing, and others. So it was really key to get all of them on board. And then we also had appointees by the legislature, by the Senate president and by the House Speaker. Now, it was really important to get this range of stakeholders because, as I just mentioned, we don't want their opposition when the bill's filed. We both wanted their collaboration. We want them on board. And plus, we want to create a coalition. We want to work together with these partners to advance the legislation this session. So once the legislation was passed, of course, then the pandemic happened. So it was derailed for a year and then came together in September 2021. We were the commission was chaired by James Lavery, who's the director of the Board of Health Professions Licensure, which was really fortuitous for us. He was appointed by in the bill, it was the chair of Health and Human Services was supposed to chair, and she appointed Jim Lavery. And that was really helpful to us because of the Bureau's close relationship with the Board of Registration in Medicine. And plus his support and help throughout the process. The mission of this commission was to improve medical services in rural and underserved areas by eliminating these barriers to practice for medical professionals up to and including pathways to licensure. So the way that we always talked about the bill was we want to leverage the skills, the cultural and linguistic skills of this population to address, and also obviously their evident desire to practice, to address healthcare shortages in Massachusetts. And I know Rob's going to go into a little more of that. And then ultimately what we ended up with was a report that was a report and recommendations released last July 1st. And the recommendations included a framework that we collaborated to provide and build support for. Those recommendations included a description of a framework that provides a full pathway to full licensure. And there's a process of the framework does not require issuance or creation of a new license, but works for a system that works from starting with a limited license and then moving to a geographically restricted license or a practice area restricted license based on the needs of the Commonwealth, and then from there goes to full licensure. So that's all I'll say for now. I'm sure there'll be questions, and we're happy to go into more details in the bill. And I know that Dr. Marlin is going to start off with that. Thank you.
Okay, thank you so much, Amy. And we'll have Dr. Robert Marlin go into a little bit more detail about the physician pathways.
Good morning to everyone, and thank you for having us. I can see it's been a wonderful discussion so far, and many resonances with many things that we've talked about in Massachusetts. So I'm glad to hear that. So my name is Rob Marlin. I'm an internist, and if you want to go to the next slide, Vanessa. So I was the, go back one, sorry.
Sorry.
That's okay. So I was the licensed physician representative for MIRA on the commission. And as Amy said, MIRA has been advocating on behalf of internationally trained health professionals for more than a decade and was really the force behind the development of the commission. Next slide. So although the commission focused on internationally trained physicians, nurses, and dentists, today I'm just going to focus on how we address internationally trained physicians. So the goals of the commission were, was charged with studying licensure for internationally trained physicians with the goal of expanding access to physicians in rural and underserved areas of Massachusetts and making recommendations to the legislature on how to accomplish this. Despite having the highest physician to population ratio in the country, we often think of Massachusetts as just flooded with physicians. Areas of Massachusetts lack access to primary care physicians, psychiatrists, and other essential specialties. And this shortage is expected to be exacerbated by physician retirement over the next several years. And we've already seen a preview of that during the SARS-CoV-2 pandemic. Next slide. So I'm going to go through some of the barriers that we identified, and I know it's going to resonate with much of what you've discussed and much of what all of you have experienced yourselves. And I just wanted to highlight just what the commission saw. So first, we're going to talk about sort of inherent barriers. The biggest one that we find often is lack of familiarity with the US healthcare system and how licensure requirements work. So one of the most common misperceptions among internationally trained physicians is that once you pass the USMLE, you will receive a license to practice medicine. And they really can be forgiven for this assumption given the name of the exam. It's very confusing to many people. A high percentage of internationally trained physicians in Massachusetts work in low-wage, entry-level jobs. Again, things you've all heard and experienced. And many struggle to find work at all, as they're told they're both overqualified and underqualified for almost any position. So they have a real loss of professional identity. Go back, I think one slide, yeah. And also they just don't have a network, a professional network in the state or the US in general. Now we can go on to the next one. Next slide. So some of the barriers we identified are structural with significant variation from state to state. So I'm going to talk about Massachusetts, but again, it will be very familiar to many of you. Just the complexity of state licensing requirements. So in Massachusetts, you're required to have non-clinical coursework. And again, to be licensed as a physician, you have to have training in some area outside of medicine, which for most people doesn't make a lot of sense on the face of it. There is also time limits to completing the USMLE exam sequence, rigid English proficiency standards, and inconsistent information from both the Board of Registration in Medicine and our graduate medical education programs. While the messaging regarding licensure for internationally trained physicians is confusing enough, these same bodies don't provide any assistance in navigating this very complex landscape of regulations. It's also costly, as all of you know, in time and money to work towards licensure, and many underemployed physicians find it difficult to even afford it. And I know you've talked about, and I think Mike also mentioned, programs to help pay for these, and that's something we don't have in Massachusetts right now. Next slide. So some other barriers. In order to qualify for licensure, physicians applying in Massachusetts have to have completed, as of now, a residency in the US. Even those with extensive experience in clinical practice outside are often forced to repeat this training. And the limited number of residency slots, their lack of US clinical experience, make it challenging for internationally trained physicians to get residency slots in Massachusetts and throughout the US. Again, you all know this. And exacerbating this are residency program policies that favor recent medical grads, with most internationally trained physicians being beyond the 3 to 5 year unofficial window when residencies want to accept people, the window after graduation. So even if internationally trained physicians do earn a slot in residency in Massachusetts, our Board of Registration in Medicine requires that they complete 3 years of graduate medical education before they can be licensed, as opposed to US grads who only have to have 2 years. So in addition, internationally trained physicians are not eligible for full licensure until after they've actually completed their residency. And why is this important? Because most of them don't get their license until about 3 months after they finish training. And this means that many of them who train here in the state can't afford to stay here because they can't get a job for at least 3 months after they finish, when most jobs are filled and they don't have the time to wait because they can't eat or pay their rent in the meantime. So whereas a number of states also allow applicants to complete the USMLE steps in 10 years, Massachusetts currently requires completion within 7 years, further pushing out internationally trained physicians who often take multiple years to land a residency slot and may not pass the exams on the first try for multiple reasons. Next slide. So some of the administrative and legislative recommendations, this is what we want to get to. So there are some general recommendations, and I'm going to start with the easiest ones, the lowest barriers. So given all the barriers we talked about, the commission developed a number of these sort of, I'd say, easier recommendations, which are administrative. They don't require legislation. And one of them is just, let's make sure the websites for our board of registration are easy to navigate, understand, provide clear information on the licensing process, transparent, with links to relevant testing organizations like USMLE and others. And this should be harmonized across all the state websites where anyone would be looking for information on healthcare licensure. And second, we want to make sure the staff at the Board of Registration and all the state agencies have training on how to interact and work with internationally trained physicians and their specific needs. This should also be disseminated to healthcare employers and immigrant serving organizations throughout the state. So we want to allow internationally trained physicians to be eligible for full licensure after 2 years of US residency, rather than 3. We actually don't know why this regulation was changed, but it's not a long-term regulation. And we also recommended that either there be a 10-year limit for completion of the USMLE exam sequence, as many states provide, or completely removing the limit, the window in which you have to complete it. Next slide. So sort of moving up the chain of not difficulty, but lift for the state. As we heard Mike talk about, and I know many of you have discussed today and at other times, there are a number of other states which are helping people, supporting them in getting into residency and succeeding in residency. So we recommend one approach is to utilize existing residency programs, designating funds and slots in Massachusetts specifically for internationally trained physicians who agree to practice in primary care, psychiatry, other much needed specialties in rural and underserved areas for, and given the cost to hold residency slots, this would be a small number, maybe something like Minnesota does with 2 or 3. And also funding a program that would help prepare people for residency, as we've talked about, so they can succeed. Next slide. So this is what I really want to spend most of my time on, and hopefully some of our discussion on, which is something we haven't seen in other states. Because of the limited number of residency slots everywhere, the cost of residency, the barriers we've all talked about, the commission concluded that an additional strategy is needed to license a greater number of these internationally trained physicians and get them into practice where they're really needed. So the commission is calling on the Board of Registration to offer, as Amy mentioned, first, a limited license. Now we're using the term, and many people will recognize that as a license used for residents. It is not synonymous with that. So we're using the existing license, but in a different way. So we want to offer a limited license to internationally trained physicians who've previously been licensed or authorized to practice outside the US have passed steps 1 and 2, and meet all the other criteria for licensure, but don't have to complete a US residency. The commission recognizes that physicians who've already completed their clinical training and graduated from a WHO recognized medical school don't need to repeat the training in the US. It's not a good use of resources for our states, and it's not a good use of time for the physicians. The focus instead is on non-clinical skills and familiarizing these physicians with the Massachusetts practice environment. We're not trying to reinvent them as clinicians. We're trying to teach them how to practice in the context of our state. They would apply to a participating healthcare organization approved by the state, which could include federally qualified health centers, community health centers, and hospitals. And the limitation of the license, again, as Amy said, is not related to their clinical scope of practice, but rather to which healthcare organizations can sponsor them. So these physicians would support their salaries through reimbursable clinical care. They're going to be working in these sites, seeing patients, getting paid, bringing in money for their organizations, at the same time adding to the clinical capacity of their sponsoring organization. They can renew the limited license until the sponsoring organization and they believe, with the approval of the state, that the physician is ready to practice independently. All right, next slide. So once the internationally trained physician has completed 2 years of clinical work under the limited license, and again, it's limited geographically, they're eligible to apply for a restricted license. Again, for many of you, that term restricted license will have resonance with other categories. So it exists as a type of license, and we're using it in a different way here. So the restriction here, again, is unrelated to the scope of practice. It's now that they're restricted to practicing in areas of the state designated by the board as most in need. So the most underserved. They must also practice in primary care, psychiatry, or another designated needed specialty by the Board of Registration. And they would again be based at an FQHC, a community health center, or a hospital designated by the state. But this doesn't have to be the same organization where they serve their limited license. So while 2 years of practice under this restricted license is required to pay back for their participation in the pathway, physicians can renew for additional years. They can stay on if they want to. Much like people do in the National Health Service Corps program, many people choose to stay in. So once they've completed 2 years of practice under this license though, they are then eligible to apply to the Board of Registration for an unrestricted license and can practice wherever they like. So we are teeing them up to be in the pool of every other physician, and they can practice in whatever specialty they want as well. Much like National Health Service Corps, they have paid their debt to the state. They have provided service to the community, and now they're free to do what they want. Next slide. So, and just for your reference, this really builds on the Canadian Practice Readiness Assessment, and I'm glad to share some information on that if people want afterwards. But suffice it to say, it's a little bit different than what they do in Canada. So in Canada, the Practice Readiness Assessment is very brief, like a number of weeks. And we are greatly expanding the time period where people are being assessed. Again, not for their clinical care, but for their readiness to practice. So I hope this is just the beginning of the discussion and will help propel forth the efforts already underway in Maine and lead to comparable efforts to develop new models of licensure in the state. Next slide. Thank you. And it's just a link to the commission's report if anyone wants.
Okay, thank you. Thank you so much. And We will make the slides available to participants as well as a recording of this. So we will figure out a way to have the information available afterward. So we do have some time for some questions or comments. I haven't been looking in the chat. I don't know if Sally has anything, but if anyone.
And don't forget, we still have Mohammed here.
Yes, and Mohammed is here from Washington State, if anyone had any questions for him.
But there is a question about how portable would the Massachusetts full licensure be when it goes through the limited license restricted process? I assume that's to other states.
We would anticipate, and I'll let Amy and Mike speak to this, we would anticipate that at that stage, it would not be portable at all. It wouldn't be until you complete the pathway and are at parity with all other licensed physicians that you could move up and go wherever you want.
Yeah, the only thing I would add to that is most states belong to the Medical License Compact. They have compacts among states for various licensed professions. And that's one of the things we're looking at is whether compact states recognize alternative pathways or only the traditional one-size-fits-all pathways. And that may require some work with the compact organization to make sure there's recognition of alternatives. So at this point, the answer is it's unclear.
Amy, did you want to respond to that as well?
No, I actually, I agree with what Rob said. The idea is since the whole point of the bill is to improve healthcare delivery in Massachusetts, and that's the point of the restricted license also after the limited license. And I just wanted, one thing I did want to mention is that the restricted, the restriction to a Massachusetts, what we're calling this in the bill is restriction to a Massachusetts physician shortage area. That's how we refer to it. And it means a geographic region or population in the Commonwealth, right? Because sometimes you can have, obviously, as we know, we have underserved populations in our biggest cities, right? So that's one thing I wanted to point out. And another thing I wanted to point out, just with regard to kind of the same issue, but also helpful politically, is what we're calling this bill is an act improving healthcare delivery for underserved residents of the Commonwealth, right? We might end up with a popular name that's something like the Physician Pathway Bill or something like that. But the point is, for states to do this, they want to see a benefit, right? Oops, excuse me, that's like horrible. That was my phone. And the other thing was, I wanted to point out that Sally Weiss had an interesting question in the chat about that I think Rob would be well placed to answer, about whether there have been any concern or thought about whether insurance companies or CMS will enroll an IMG that went through an alternative pathway to licensing. And that is something we did talk about in some depth in the commission and why we came up with the framework we did. Rob, would you explain that?
Sure, I'll talk
You don't
briefly. I think
mind?
Mike also can speak to this. The key is, and I think where the question comes from is, we know that CMS is very hesitant not only to look at new license categories, but to allow them to be reimbursed. And it's a very heavy lift to try to do that. I can't even think when the last time a new license category was created, and there's good reason for that. So that's why, through some very wise advice, we decided to focus on existing categories of licensure so that there's no issue with CMS. But Mike can spell it out a bit more.
No, that's exactly right, Rob. The hardest thing in the world is to create a new license category within CMS. So to assure that the reform you're going to put in place actually works, it's easiest to use existing statutory license categories and move the pathway into those categories so you don't have to have the insurance fight.
Thank you. I just want to call on Mohammed. Khalif has raised his hand. Did you want to add something, Mohammed?
Yes, just wanted to add something to, Dr. Mullen's point, which is Missouri had that problem because they created a completely new category and then they had issues with CMS, just already using, the existing categories and leveraging that. With our limited license right now, we're not seeing more of an issue. The only issue that we've seen here in Washington was with medical malpractice, and that was because of a bad and provision in the law that we're changing this session. So as long as you don't mention malpractice in your bill, you're good.
Great. Thank
Yeah,
you.
the Missouri bill that Mohammed is referring to is the assistant physician model. First in Missouri, it's been looked at in other states. It's an alternative pathway for physicians, but it does not lead to full licensure. And Mohammed is absolutely correct. They created a completely new license category, and the insurance companies and CMS just had fits with it.
Yep. Thank you. We just had one more question, if it was a short answer, and then we're going to move on to keep time, but it will be available afterward. Somebody asked, in the Mass legislation, would a graduate from a U.S. school be able to go through this pathway?
Vanessa, I'm going to ask that Jose Ramon answer that and also say whatever he was going to say.
Go ahead. You're on mute.
So Ramon, maybe you want to put it in the chat because we can't hear you for some reason.
We can.
Can you hear me now?
Oh, yeah, yes.
Yep.
Sorry, the comment I wanted to make was that for many of us, this concept of a payback for education or for opportunity will not be a foreign concept. Certainly speaking as a Mexican, after 4 years of medical training, we have a 5th year where we pay back the country for our practically free education in a form of a 1-year internship in general medicine, surgery, peds, and OB. So it's not unheard of. It's part of our training. It's part of the requirements for licensure. So I think that's a brilliant take on what you're doing in Massachusetts. So that was the comment. And I didn't hear the question.
Would it be available, the Massachusetts legislation, to U.S. citizens?
U.S. citizens
who went to, let me pull up the question. Sorry.
Yeah, you're saying, would it be available to IMGs who are U.S. citizens?
Yes.
Yes, I mean, there's no restriction about citizenship here. The restriction is the definition of, so this applies only to what we're calling an internationally trained physician. And the definition we have is a physician who has received a degree of Doctor of Medicine or its equivalent from a legally chartered medical school outside the United States, recognized by the World Health Organization, who has been licensed or otherwise authorized to practice medicine in a country other than the United States, and who has practiced medicine for at least 1 year.
And you'll notice that we don't use the term IMG because we want people to have been in practice.
Right.
So it's not just that you have to have graduated. And again, part of it's just the strangeness of US terminology, because in most countries, if you graduated, you've been in practice, right? But it's not necessarily the case here. So we're trying to make the terminology clear for legislators.
Thank you. And thank you so much to this panel. We are going to move on. We have, and I just want to, the New Mena Resource Center, when we worked with many stakeholders, we came up with recommendations as well. And we have a report on that that's in background materials. More than happy to share that as well. What I want to say before I introduce our final speaker is that one thing is clear, we have similarities and differences with other states, but opportunities and pathways are really going to be created together by stakeholders. And that's important. I want to introduce our next and last speaker, who is Representative and Assistant House Majority Leader, Kristen Cloutier. And she has sponsored some legislation, an act to establish a commission regarding foreign trained physicians living in Maine. And I'm just going to say a few things about Kristen, and then turn it over. I just want to say that she's serving in her 3rd term, and she is from Lewiston. And Representative Cloutier has introduced and passed legislation to decrease barriers and streamline business licensing, so qualified new residents who can enter Maine's workforce, so they can enter the workforce, and expand support for new Mainer populations across the state to become work ready while they're waiting for their work permits from federal immigration authorities. So a lot of the work that she has done in the past are currently benefiting the participants and students that we are working with right now. So thank you so much, and I'll turn it over to you.
Thank you so much, Vanessa. And thank you all so much for having me today. It is so exciting to see over 100 folks on this call. And so I'm super excited to be here, really humbled to be here, and happy to have been asked to sponsor this piece of legislation. My district is Lewiston, and we have a very large asylum-seeking refugee and immigrant population from Africa and various other places. And so throughout my time in public service, this has been really a priority and a focus of mine. And so the bill that I am introducing this session is an act to establish a special commission regarding foreign trained physicians living in Maine. And I'm happy to work with Vanessa and Sally on the drafting of this legislation. It aims to examine and address the healthcare workforce shortage by looking at how to best integrate foreign trained physicians living in Maine. It would establish a commission that engages a wide range of stakeholders, and those include, but are not limited to, healthcare employers, immigrant advocates, workforce development professionals, those who sit on licensing boards, members of the legislature, as well as the governor's office and foreign trained physicians. So a really broad swath of experience and expertise that we're bringing to the table. And they will issue a report of recommendations by August of 2024. And there are 3 major goals of the commission. One is to explore a wide range of options for how to best utilize the unique skills, training, and talents of foreign trained physicians who wish to live and practice in Maine, to increase the healthcare workforce cultural competency, and to address our workforce shortages. And paramount to all of this is really to take advantage of the experience and expertise that so many of our foreign trained physicians have, and make sure that we're allowing them the opportunity, not that we're allowing them the opportunity, but we're making it easier for them to support their families and continue to do the work that they love. I want to be clear that the bill only seeks to convene stakeholders and figure out how to utilize credentialed doctors. We're not actually proposing legislation on how to do that. We really sort of want to get the opinions of those who are most affected and involved. We really want to figure out how to utilize those credentialed doctors who aren't currently licensed in the state to meet the needs of those physicians, their patients, and employers. The commission will also lean on the expertise of others and will review and identify best practices, learning from similar efforts in other states, like in Massachusetts, as we heard today. And then there will be, obviously, as there is with all legislation, opportunities to hold hearings and invite testimony from experts and the public. And the report quite possibly will include guidelines for full licensure and conditional licensing of foreign trained medical professionals, but also other recommendations for the types of strategies, programs, and support that would allow physicians to utilize the fullest extent of their training and experience. So I think we're talking a lot about credentialing and licensing, but I think that in addition to that, we are going to want to take a look at sort of wraparound supports for those folks and how we best support them in their communities in the broader sense of their lives in Maine, in addition to their employment. So that's all I have, and I'm totally open for questions.
Thank you so much. What we talked about, we're going to have bring Judy Ann from the Hanley Center is going to come back and close it out, but we're inviting people to stay after in case there's any other questions. So thank you, and Judy Ann.
Great. Thanks, Vanessa. So, wow, what a very full and informative 3 hours. Thank you all so much for joining us today and this morning, participating. Thank you to all of our speakers and the sponsors. I hope you all took away some pieces today that enable you to either go back to your place of work or your community and think about what you can do in support of this work within your sphere of influence, and to certainly follow along. I have no doubt that Vanessa and Sally will keep all the folks that enrolled for today informed of what's happening and to follow along with that legislation, because more than anything, this is a process around collaboration and stakeholder input. And so I think that's what really the legislation is all about. And hopefully they'll hear a lot of input that will be very helpful to move forward. I always talk, when I talk about my organization, the Hanley Center, in terms of our namesake, Dr. Dan Hanley, and his values. And today what I heard were about all the values of the Hanley Center. And I just want to share them with you because it's so important. And I think that all our speakers exhibited our values are collaboration, hard work. This is such hard work, innovation, inclusion, kindness, and courage. And I think that if we used those values in these conversations going forward and keep an eye on those values, I think we'll come up to some solutions that will help everyone. So as Vanessa just shared, there's going to be an open space right now on this Zoom. So if you want to stay and have some more questions, some of our speakers will be staying. Vanessa and Sally will be here. We'll keep this line open for continued conversation. And if not, just keep an eye on your inbox, because I have no doubt you'll hear more about this in the future. So from the New Mainers Resource Center and Portland Adult Ed and Daniel Hanley Center for Health Leadership, I thank you again, and I hope you have a very healthy and joyous 2023. Thank you all.